Welcome to Let's Talk, a place for straight talk, hard topics, and smart people. I'm Sue Wallace, CEO of Oximetry, and thanks for joining me today. I'm very happy to be here with James Crowley and Dustin Osborne to talk about radiopharmaceutical therapy in the clinic. James, Dustin, you are two of the people I think represent the most mature radiopharmaceutical therapy programs in the clinic today. That's why I'm so excited to have you here. You're also doing dosimetry. I know you're also billing for dosimetry. And these are questions everybody has. Can I get paid? How much imaging? So I sort of want to dive into all of these topics and hear the realities of making this work and the challenges and what your answers have been. I'm going to start with James, though, and just say, from a dosimetry perspective, you've been doing radiopharmaceuticals for quite a while, therapies for a while. Why now are you saying, let's bring in the dosimetry, let's kind of take that step up? Why now?
Yeah, I think the why now is a good question. I would say we've been doing dosimetry since about 2016 with Surspheres. So I would say it's not new. Folks are pretty used to doing dosimetry on that type of therapy. But now we're starting to ask questions related to Pluvicto and Dotatate, and obviously what's coming. Our clinical trials are starting to include dosimetry. We know that the patients that we're seeing are not the patients that are studied in the clinical trials in the clinic. So we're seeing a need to be more mindful and safe. We need to know where these isotopes are going. We're learning through discussions with colleagues that the patients present differently. They can have unique changes to what's going on with them, infections and whatnot, that really change their way of excretion. Mm-hmm. So it's time to really understand, not just we know we can inject it in, where is it going? How's the patient doing? Mm-hmm. And then have a record for the future. That's why we say now. We know these are moving earlier. Our clinical trials are moving earlier in the disease processes, and we need to be able to understand 5-10 years later what that patient experienced.
Yeah. So what I think, because I want to check part of what I hear you saying, there's let's be safe, that's part of it. But there's another part that just says, and I'm putting words in your mouth, we're still early in this field. Let's keep track of what we're doing. Is that a fair summary too? You say, let's put this information into the record. Let's understand what these patients are receiving. Dustin, do you agree with that?
Yeah, that's really one of the biggest reasons we do dosimetry is that we actually are able to keep track of everything that we've done, at least have an idea of what that dose was for the patient. Because we have situations where a patient, that may experience extreme fatigue, end up having to go to the hospital because they feel like they are so fatigued that they cannot deal with that situation. And then we've had people call to have, radiation oncology wanting to do, palliative spine treatment in order to help with the pain. But if we don't have an idea of what radiation have we already delivered to that patient in that specific area, then it's really difficult to understand whether or not it's safe for them to continue with a palliative treatment sort of plan. And there's been a number of cases where we've sort of helped guide that because we actually had this dosimetric record. And it is about the newness, right? Everyone's used to Y90 dosimetry. It's very simple because you once you get the beads in, the spears in, they stay. They don't go anywhere. They don't move. And it all is just assumed to be the physical half-life of the isotope. But with radionuclide therapies, it's changing. You have to rely on the patient's metabolism, which is a different level of understanding than a lot of places are really used to having to deal with. And so it's not just about then the one time point trying to measure this. You really need to understand the clearance of the patient and their specific metabolism for each organ in order to have an idea of what's happening. So I think that it's the record, and it's understanding what we've done in case we do have any sort of clinical occurrences that pop up. That then we have an understanding of whether or not did we cause that, or is the dose in the area that we're looking at or that could have been affected, there's no way our dose could have done that.
So I'm just going to challenge you for fun. Of course you think that. You're the physicist. You guys like to measure stuff, right? Do your physicians agree with you? I mean, what do they see as valuable information to capture? I agree with you, by the way, but just curious across the clinic.
Yeah.
Did the doc see it the same way?
Ours seem to be appreciative of it. So, we operate probably differently than a lot of places in the country do. But we send out reports to the physicians after the fact. So once we have the radiology report from our AU, which is a radiologist, and then we send those out to the referring physicians that have information and summaries about the patient. So we're keeping in constant contact with them about why the dosimetry is important, right? And here's things to look for in their clinic. So as you know, once they go out from us, where we don't necessarily see them for the ultimate follow-ups on everything, that way they know what to watch for, what they need to be looking for. And they do seem to be appreciative of that. And I think the patients, they initially, when you tell them they got to come back, 5 days later for an imaging session or something, it seemed inconvenience. But when you talk to them about why, it seems to be okay.
Yeah. What are you hearing from your patients?
I'd like to
James?
answer that one too, if you don't mind, because I think we have a slightly different thought. I would say a month ago, the clinicians did not want to do dosimetry, but I think, because what we did initially was about 100 patients. The first 100 therapies we did, we imaged them, we tracked them. Didn't seem to matter. It didn't change anything. We can't escalate the dose. They won't give me more. But then I think we were asking the wrong question. It wasn't so much that what changes. It's do you have a defendable position? Frankly, we live in a litigious society, so we need to have a better understanding. It was, in conversation, it was the only thing we're not looking at. Every other isotope I inject, we see it. We know what's happening. And I have bad tags. We have pharmacovigilance reports of other isotopes, and these are all new, So I think we have moved to the position of we know this is coming. The treatments are becoming earlier in the disease process. We know it may not matter as much currently, but there are places, for example, dotatate. Folks are starting to do more treatments. So not stop at 4, and then just to start to understand in that young female patient, what if you gave her 5 and 6? What if you gave her 8, 10? Does that actually impact her overall survival? We know it helps with symptoms, but there's very little complete responses in the overall treatment of dotatate patients. So I think that's the better question of currently why it matters, in my opinion.
Oh, James and Dustin, I hate to stop this conversation. There's so much here to learn from what your in the clinic experiences are. This has been great. We may have to do this again, but thank you so much for joining me. And so that's my official close. Let's talk again. Yeah.
Very good.